contrast, then some of them will get that. But if you give a control group of people contrast, just as many will. Oops.
So it's not.
Okay, most of the studies that do that kind of control, we found no difference between control and contrast receiving people at all. A few have found a little. However, they're all retrospective. We have 100 people at contrast, let's see, it's control, we have 100 people who took some contrast,
Right.
so let's try that.
Right, right.
As with all retrospective control, that problem appreciates the control population is identical.
Right, right.
And criticism, valid criticism of the levy of this all the same. Maybe the reason we show that is that doctors are smart. They always give us a place. They send those people to contrast, and so that's a sicker
Sure, I think that's true. Yeah.
So maybe contrast really does something, and it doesn't look any worse than that sicker bunch.
Right.
But if you looked at an identical bunch, it would.
Right, right.
So two huge studies that in order to deal with that, by using this study on both arms, using propensity matching analysis. One of them, University of Michigan, showed that most people who get contrast don't
Right.
And even bigger ones, we had a clinic showed no difference whatsoever.
Interesting.
The Mayo Clinic one also had a subgroup of 8,000 people, each of whom had contrast enhanced and a non-contrast.
Yeah.
And the 8,000 people, about 4,000 of them had one order and 4,000 had another.
Right,
So
right,
there's
right.
some close
Right.
no difference. None. The same group from the Mayo Clinic did a study. Again, they're trying to study the hypothesis that just a small fraction of people
Yeah.
small fraction died. Found no evidence that it took zero. I think those appear since the last time.
Right. Yeah. Yeah. Absolutely. You should come give grand rounds.
Well, periodically,
You do. I know. But you're right. If there's new data, I mean, I think that'd be very interesting. If what?
How are you?
Yeah, man, Christoph's in charge. He's a boss. He's a big boss now. He didn't. I didn't want to be like. Ah. Oh no, I haven't looked yet. I figured I'd give the lecture first, and then I would. Some fiddling. I didn't look yet. I figured I'd let me give the lecture. Yeah, so he didn't. I hope. I mean, now I guess
It wasn't that exciting.
I think you made the right call.
All right, guys, shall we start? Yes. All right. Good morning. My name is Maya Rao. Shout out to my group. Thank you. I am one of the nephrologists in the division, and I'm going to be talking about chronic kidney disease today, jointly presenting with Dr. Newhouse, who is going to be presenting the radiology portion of the talk. Okay? No disclosures. So in terms of teaching objectives, so today a few things we want to focus on is the importance of equations to estimate glomerular filtration rate, to go through the diagnostic workup of chronic kidney disease, to understand the role of imaging, to go through some of the extrarenal manifestations outside of the kidney, and then we're going to talk about proteinuria and hypertension as the major treatment targets in CKD. So to accomplish that, we'll go through a definition, the etiology and the pathophysiology of CKD. We'll go through a case, diagnosis and the imaging, and then consequences and treatment. So what is CKD, chronic kidney disease? So chronic kidney disease is when there's been some irreversible damage to the renal parenchyma. And there's a wide spectrum of primary diseases that can cause CKD, but in the end, all these different things lead to a characteristic decline, which when you do a biopsy, you basically see glomerular sclerosis and tubulointerstitial fibrosis. So no matter what the primary cause of the kidney failure is, these are the things that you would eventually see. And it's important to distinguish this chronic kidney disease from acute kidney injury or acute renal failure. And the main way you would do that is by the time course, acute versus chronic. So AKI is something that happens in a short amount of time, sort of days to weeks, whereas CKD is something that's happening over a longer period of time, more like months to years. And the consequence of that is that in AKI, your GFR sort of suddenly drops to almost nothing, and you can't regulate volume and solutes because it's happened over a quick period of time. There's no time for the kidney to adapt. And so in this setting, somebody will get AKI, you'll see the hyperkalemia, you might see volume overload. In CKD, it's happening over a slow period of time. There's more time for adaptation. Single nephron GFR can go up. And so you'll actually still have normal excretion of volume and solutes. So even in someone whose GFR is 20, you usually don't see hyperkalemia. Their volume may look fine. So those are kind of the big differences. And AKI often is reversible. With CKD, it's really a progressive decline. So what's the definition of CKD? And there are sort of different definitions. This is one of our societies, the KDIGO Society, that puts forth guidelines. And so here they're talking about CKD as having an abnormality of kidney structure or function, and it should be present for more than 3 months. So again, this distinguishing between something that's happening acutely. So you can have it because you have a marker of kidney damage, which is albuminuria, some urine sediment abnormality like hematuria, and other abnormalities you might see in a biopsy. But the other criteria is really having a decreased GFR. And so if you have that, you have chronic kidney disease. So you've learned a lot about 24-hour urine creatinine clearance, and that is a way to sort of estimate GFR. But in clinical practice, we really don't do it very often. We do it sometimes, and the reason for that is very cumbersome for a patient to have to collect their urine for 24 hours and bring it in, and there's a lot of inaccuracies just because they don't collect it properly. So these equations have been made to estimate GFR, and both of these are widely used, and they've been validated in different populations. So the bottom one is the MDRD equation, and that is sort of the original one that's really in widespread use. And you plug in the patient's creatinine and their age, and then there's a correction factor for gender and race, taking into account that females in general have a lower muscle mass, so they'll have a lower serum creatinine for the same GFR, and in African Americans a higher muscle mass. And nowadays on most lab reports you'll actually see it'll give you the eGFR, and that's usually done from the MDRD equation. The CKD epi equation is the newer one, and it's probably going to become eventually more used than the MDRD equation. And this is the reason for that. So this is a study looking at here the estimated GFR by the equation, and then the difference between the measured GFR and the estimated GFR. So if the equation is doing perfect, you should be at this line at 0. So if you see the MDRD equation here, it actually tends to underestimate the actual GFR. And this particularly is a problem when you get to a GFR greater than 60. So when using the MDRD equation, if the GFR is greater than 60, we usually just say it's greater than 60, and you don't give an actual number like 80 or 90 because it's just not felt to be that accurate. And again, it's underestimating the GFR, so the true GFR is probably higher. So the CKD-EPI equation was really created to sort of deal with this problem of underestimation, and you can see that it does do a better job even at higher levels of GFR. So it's probably going to become more and more the standard. There are some caveats, though, to using these equations, and just with your creatinine clearance, the biggest thing is the steady state. You can't use these equations if you're not in a steady state. If your creatinine is rapidly changing, you can't use the equation. So you would not use this in somebody who has AKI. If the creatinine is in steady state, then you can use it. And then there are other things that make the equation sort of less accurate, most of which you don't have to really focus on, but just realize that it's been validated in certain races and ethnicities, so that's one thing. And that when you have extremes of body size and muscle mass, somebody who's a huge bodybuilder who might have huge levels of creatinine because they have huge muscle mass, I mean, this equation is probably not going to be that accurate. Or on the other side, someone with very, very low muscle mass. So the most important point of all of this is that you need to calculate the GFR, okay? You cannot look at someone's creatinine and just know what their GFR is because it's very different depending on the demographic of the patient. And so if you're in a steady state and you're seeing a creatinine, you're thinking about somebody's kidney function, you need to calculate it using one of those equations. It doesn't matter which one. And just to give you some examples, this is the reason why. If I have a 78-year-old Caucasian woman with a creatinine of 1.6, by the MDRD, her GFR is 31. If you have a 42-year-old African-American man, their GFR is 58. And that's a huge difference with the same creatinine. So just to bring home the point that you really need to calculate it, because obviously this would have a huge implication for drug dosing for the patient and also just telling them about how their kidney disease is doing. So whatever equation you want, pick your poison, estimate it, use it. There are online calculators, mdrd.com, nephron.com. If you guys have these calculator apps on your phone, it's going to have this. And actually, a lot of the lab reports do it for you automatically. At Columbia, it's the MDRD report right now. So we talk about CKD in stages, and this is put forth by the National Kidney Foundation, and this is what everybody uses, so you should know it. And basically, people are staged based on their GFR. And I'm just going to focus on 3, 4, 5 because that's really what most of the patients we're dealing with who have real kidney disease is 3, 4, 5. So stage 3 is having a GFR between 30 to 59. And at that point, you should be looking at a patient trying to figure out what their kidney disease is from. But once you get to stage 4, which is a GFR between 15 to 29, I mean, at that point, you for sure would refer a patient to a nephrologist without question. You probably would in stage 3 too, but by stage 4, you really need to. And at that point, we're often starting to talk to patients about renal replacement therapy, whether it be dialysis or transplant. And then stage 5 is less than 15. And that's very advanced kidney failure, and at that point you're definitely prepping a patient. And you'll hear people use the word end-stage renal disease or end-stage kidney disease. That's just if you're on dialysis or you've had a transplant by definition. So there are a lot of people with CKD in the United States, so no matter what you guys end up going into, you're definitely going to see patients with CKD. So you can see here, just since stage 3, which is definitely having implications for health, there's about 15.5 million people, and this is then stage 4 and 5. These numbers have probably increased because of the prevalence of diabetes and hypertension. CKD is on the rise, and this doesn't include all the people on dialysis. So as I mentioned, there are lots of different causes. Anything that can cause kidney damage can lead to CKD. So in the United States, diabetes is the most common cause of CKD, with about 30% of people who are on dialysis having diabetes as their primary cause of kidney failure. And then the second cause is this vascular disease, of which probably most of it is this basket hypertension. And then, of course, everything you guys have talked about, all the glomerular diseases, cystic diseases, tubular diseases, they can all lead to CKD. So as you know, we've discussed, there's the primary process, the disease that is inflicting the initial damage, and then the secondary process. So these are not anything to do with the primary disease. These are adaptations that the kidney is doing to keep the GFR up that are eventually actually causing more damage to the kidney and lead to a progressive decline in kidney function. So make sure you memorize this whole slide for your test. Just kidding. So this is more to give you a vague picture. You do not need to know the details. It's just to understand that when you lose more than half your kidney mass, that's when you start having these sort of maladaptive processes. And as you've talked about a lot, you have activation of the RAS system, people develop hypertension, and there's adaptations in the kidney trying to keep the GFR up. So you have increase in glomerular hypertension, single nephron hyperfiltration, but eventually all of these things are sort of leading to a process of glomerular sclerosis and fibrosis. And so all of these things basically lead to increased inflammation, and there's cytokines that are released that kind of increase fibrosis in the kidney. And this cascade here affects every single cell in the kidney. You know, it affects the mesangial cells and the podocytes, causing hypertrophy and apoptosis. Same thing in the tubular cells. And the cells often take on this sort of fibroblast-like phenotype, and that leads to matrix being laid down in the kidney and fibrosis. So in the end, you end up with glomerular sclerosis and interstitial fibrosis. And as we've sort of discussed, that your nephrons can compensate for a loss in kidney mass, and so you really can lose up to 50% of your kidney mass, and you wouldn't see a change in the serum creatinine. If we take a kidney out for kidney donation and you check somebody's creatinine, let's say in 2 weeks, assuming the other kidney's fine, their creatinine should be going back down to baseline because the single nephron GFR can double. So you have to think that if you see somebody's creatinine has gone from 1 to 1.5, there's been a huge amount of damage sustained, right? Because you can lose half your kidney mass and your creatinine shouldn't change. So just keep that in mind. So how do we diagnose CKD? Where the first thing is you need to differentiate, is it acute or chronic? So obviously if you have somebody who has 20 lab results in the computer over 2 years, that's very easy. You can look at their creatinine and see what's happening. But sometimes, unfortunately, people show up and you just have this lab value and you don't know how long it's been going on. I just saw a 28-year-old girl show up in the hospital with hypertension and obesity, and she had a creatinine of 2.5, and we had no idea if that was new or old, and it makes a big difference for how we would work her up and different things. So you also can look for manifestations of chronic disease, and I'm going to go through that in a little bit, but things like anemia and bone disease, and then imaging can be extremely helpful in this situation. So when you see somebody with this, the BMP is the basic metabolic panel. So this is getting all the electrolytes that you've been talking about, the bicarb, the BUN, and the creatinine. And then we always do a urinalysis and a microscopic exam. So we're looking for proteinuria, which is very important. And then we're looking to see if there's red cells or white cells. This is what we call an active urine sediment. So maybe then you'd think more that somebody has glomerulonephritis. And then quantifying the proteinuria, so not just the dipstick where it'll tell you 1 plus 2 plus, but actually quantifying is very important, and I'll talk to you more about that. A renal ultrasound is a standard part of the workup. Everybody should get a kidney ultrasound. You don't want to miss obstruction, and it can be very helpful, again, to determine chronicity of disease. So just to quickly go through a case here, this is one of my patients. So a 44-year-old woman presented to me in clinic. So she's obese. She's had type 2 diabetes for 15 years. She has end organ damage, so she has retinopathy. I think we would have talked about this in your small group yesterday. And she has hypertension. It's been very poorly controlled. And she's coming. She feels fine. She doesn't know why she's here. She's here because her doctor told her there's some protein in her urine. And she has a little bit of swelling, but she's used to that. It's not that bad. Maybe some shortness of breath after walking. But she feels pretty well otherwise. She wouldn't have come if the doctor hadn't told her to come. So she's 242 pounds, her blood pressure is 170 over 80, and she has a pulse of 90. And her exam's pretty normal, except for a little bit of lower extremity edema. So we check her labs. Her potassium's 4.4, so she's got a normal potassium. Her bicarb is 19, so it's low. And the BUN is 30, the creatinine is 2. So that's a GFR of 27 by the MDRD equation, which puts her at stage 4 CKD. So despite having pretty advanced kidney disease, stage 4, she's fairly asymptomatic, and her potassium is actually normal. She has some anemia. Her hemoglobin's 10-1. There is proteinuria on the dipstick, so 3+, but we don't know how much because we haven't quantified it. So we do the spot urine, protein, and creatinine. I'll get into that more in a minute. And she has 6 grams of protein, which is a ton of protein. That's nephrotic range proteinuria, probably from diabetes. And then, as I said, we always do an ultrasound, and she doesn't have, her echogenicity is normal, which Dr. Newhouse will talk to you about, and she's got a right kidney that's 12/9 and left that's 12, so those are certainly normal size, certainly not small, maybe even on the big side. And just to let you know, this patient actually ended up getting a kidney transplant eventually from her son, actually, and she's doing very well now with good kidney function. But we will move into imaging.
Well, good morning, all. My name is Jeff Newhouse. I'm a radiologist. I'm actually a urinary disease radiologist, an occupation which you probably didn't even know existed. There are perhaps 200 or 300 of us in the entire world. But I like to make pictures of people with kidney diseases to see if we can figure out what goes on with them. And indeed, that particular occupation involves a sizable chunk of radiology. If you have a patient who comes to you with either acute or chronic renal disease, almost always that patient is going to be sent for imaging, and I want just to outline for you a moment of how that works. You've been hearing about, and probably by this time know a lot more than I do, about the mechanisms of renal disease, but when you first encounter a patient who's got renal failure of some degree and of some duration, but you don't really know what it is, one of the first handy classification tasks to help you managing the patient is to try to figure out which of these three categories this problem falls into. Pre-renal failure, that is this somebody whose kidneys are working or would work fine if the circulatory system would get enough blood to them at a high enough pressure? Does the patient have something wrong with his or her kidneys innately to the renal parenchyma and its function? Or are the kidneys and the blood supply working just fine, but there is ureteral or bladder obstruction such that the urine pressure rises and things go wrong essentially because of that? And the way you distinguish among these three things really is radiologic first. In a patient with pre-renal failure who has chronic renal disease, almost always what you find is the patient has a very tight renal artery stenosis, or assuming the patient has two kidneys, two tight renal artery stenoses, so the perfusion pressure of blood going to the kidneys is diminished beyond anything that the kidney's autoregulatory system may take care of. There are a number of ways that you can look at it, but I'm going to show you this one, not because it's necessarily the first thing you do, but because it shows you most dramatically. What this funny-looking picture is an arteriogram. What the patient has had is to have a small catheter, which you can faintly see running up the aorta there, inserted through a puncture in the femoral artery until the end of it is in the abdominal aorta above the renal arteries. And then contrast medium, don't worry about what that is, we radiologists use it all the time, however, contrast medium is injected so that wherever the blood goes, it carries the contrast medium. Whatever the contrast medium is, you can make a very clear picture of the inside of the blood vessels. So here is this patient's right and this patient's left renal artery, and you notice that what ought to be of uniform diameter like that, point of fact here is extremely narrow and here is extremely narrow, so that the pressure downstream from them is never going to be as high as it should be. Kidney blood flow will diminish. Chronic renal failure will become manifested. Now, many times, patient's renal circulation is just fine. So some of the other things that you may see then, looking at a patient with chronic renal failure, are some of the things that you see here. You may see tubulointerstitial fibrosis, or echogenic kidneys by ultrasound. You've already had, in this case, it quotes echogenic kidney. You may wonder what in the world an echogenic kidney is. I'll show it to you in a second. And you may wonder what disease tubulointerstitial fibrosis is. Well, it's not a specific disease. What it is kind of a final common pathway histologically. That is, much more fibrosis in the renal parenchyma than there ever should be, which may not tell you, once you find it, what disease the patient has had, but at least it puts the diseases in a category. Imaging may show you renal parenchymal volume loss. One of the things that's true about small kidneys when you see them is that they never grow back. And so if you're trying to figure out what's going to happen to your poor patient, finding out that a patient has very small kidneys leads you to, well, the necessity to manage chronic renal failure for the rest of the patient's life, or possibly to send the patient for transplant. There are diseases which can cause enlarged kidneys. We'll take a look at some of those. There are diseases which cause obstruction, and when we say obstruction, almost always what we mean is obstruction to urine outflow. Ureters get obstructed, prostate gets too big, bladder gets obstructed, and kidneys don't work as well. Cystic disease you will see in a subsequent presentation. So let's take a look at just a couple of these. Here are ultrasound pictures of the right kidney, and actually this is of the right kidney in two different patients. Looking at them, I realized what I should have done if I'd had my wits about me was to show you in comparison a a normal kidney, but let's look at this anyway. There's a kidney sitting right there. Okay, it looks lighter gray than this. If you look at these regions, this is liver, this is kidney, never mind what the other things are, you notice that they're essentially full of white speckles. The more white speckles there are, kind of the brighter on the image, whatever it is, looks. And that is a standard ultrasound picture. You notice that this entire kidney looks much, much more full of bright speckles than any other tissue you see around there. And I can tell you that that brightness, that sort of conglomeration of white speckles, is absolutely abnormal. What that tells you, if you see it, is that the patient has tubular interstitial fibrosis. And as I've said, that does not tell you exactly what chronic renal disease led to it. It does, however, tell you that the chronic renal disease has progressed to a point at which this kidney has functional and anatomic loss which it will never recover. What in the world is this? Here we're looking at a CT. I haven't sat there with you since your first day in medical school, so I don't know how many abdomen CTs you've seen. I'm going to assume it's somewhere between few and none. So let's just talk a word about what this is. The CT, which stands for computed tomography, is essentially a fancy X-ray picture, and you can aim it at any body part that you want. In this particular case, it has been aimed at the upper abdomen. Now, the way these slices are made, kind of like a magician, a slice is made through a patient. You can pick where the slice is, sort of saw the patient in half. And by tradition, the images are shown as if you sawed the patient in half. Let's say you sawed me in half at the level of my kidneys. You threw the bottom half away, tilted the whole thing over, and then looked at the cut-off surface from the bottom. So if you were standing where my feet are and my legs were and my legs aren't there anymore and looked at kidneys, you might see a view that looked something like this. So this is the posterior part of the patient. This is the anterior part of the patient. That's the patient's right side. That's the patient's left side. Some of the things here you probably recognize instantly. There's a vertebral body. These little white flecks here are ribs cut in kind of an angle. And here are the patient's kidneys. I can tell you that compared to normal-sized kidneys, these are tiny. The patient that you've just had presented to you had kidneys whose lengths were, I think about 12 and 13 centimeters. These kidneys would have lengths of perhaps 3 or 4 centimeters. And to repeat, once you see this, since you know kidneys never regrows parenchyma, this person's renal failure is permanent. We don't know how it got that way. There are a number of diseases that can wind up looking this way. But in a sense, once you get to that point, it kind of doesn't matter. Treating the patient under these circumstances becomes much more important than diagnosing how he wound up there. Here is a manifestation of a disease about which you're going to have a chunk of a lecture about a week from now. This is one of the polycystic kidney diseases. There are several. They're genetic. This is one, an autosomal dominant polycystic kidney disease. It's sort of a medium common one. There are thousands and thousands of people around the United States who have it, enough so that there's actually an association of people who have it, and they promote research into it and so forth. This is a CT also, but it doesn't look like the one we saw before. It doesn't look like somebody who's been cut in half. All CT images are originally taken as if the patient were cut in half in a transverse section. But if you have a whole bunch of such slices and they're thin, it's an easy computer trick essentially to recreate an image through any other plane you want to demonstrate things in the body. So this patient had that, and this is a coronal plane, as if the patient was sort of sawed right down here. Okay, front part was thrown away, and you're looking at the cutoff section looking backwards. So the patient's facing you. Here, obviously, are vertebral bodies. There's a liver sitting up there. There's a spleen sitting there. There's a stomach there. And if you wonder why the stomach is white, remember, we radiologists like to fill parts of patients with things that make them easy to show up. So the contrast medium that went into the stomach here is there for exactly that reason. And here are the right and left kidneys. Once more, if you could see a normal one right next to each of these, you would see that these are twice or 3 times the volume that any normal kidney ever has. And they are full of these dark gray circles and ovals, each of which is a cyst. The only thing that remains of these kidneys functioning parenchyma are the little bands in between. So if you look at total amount of functioning kidney left under these things, it's a tiny, tiny fraction of what it was. You can make a specific diagnosis from this and also get a pretty good idea of what the patient's current renal function will be. And you also know, finally, once you've made this specific diagnosis, that the future for this poor person's kidney health is nowhere but down. Now, what in the world are these? Remember that ultrasound I showed you with all the white speckles? These are ultrasounds of a patient, of a right and left kidney, in a patient who had the same disease. I've just flipped the ultrasounds around so they're kind of oriented the way these kidneys are. And now, rather than having very bright kidneys, you have dark circles filling up most of the space where the kidney used to be. These are the cysts. Now, if you think a patient may have this disease, or if you're following a patient with this disease and you're trying to figure out whether to do this or this, a couple things to keep in mind. And this is going to be important almost no matter what specialty you go into. Ultrasound versus CT. Ultrasound is cheaper. Ultrasound is safer. There's no radiation exposure. There's no contrast that can do any bad stuff to you. Ultrasound is almost universally available. It's the quick, easy way to start, and often, as in a case like this, it will give you all the imaging information you need. Its only drawback is that it tends to look at little bits and pieces of people rather than the whole thing, and if you look at somebody's kidneys, you may, by ultrasound, you may miss the big adrenal tumor, the big liver cancer, something of the sort. So, with all those advantages, there are some limitations on what it can show you. Still, it is the way to start when you're trying to figure out why kidneys don't work. Finally, now, post-renal failure. Whenever anyone has an obstructed ureter or obstructed outflow from a bladder, there is a chronic elevation in pressure upstream from that obstruction, and whatever those structures are, dilate. So, the collecting system in the kidney, the calyces, the renal pelvies, will get much bigger in volume than they were. The ureter upstream will get to be much bigger than it used to be, and these very much lend themselves to pictures being made by clinical radiology. So let's take a look. This is another kind of image we can make. It's a kind called an intravenous pyelogram, and what it essentially means is we give contrast intravenously, the kidneys excrete it, they concentrate it in the urine, so any place urine goes now looks bright. So you can make very pretty pictures of calyces, the renal pelvies on both sides, the ureters, and the bladder sitting down here. It gives you an instant look at whether these things are healthy or not, but I should tell you I'm showing you this because it's an anatomic demonstration. For a variety of reasons you don't need to worry about anymore, although these are extremely commonly done up until fairly recently. They've almost all fallen into disuse for part of CT. But for looking at pictures of things, you can't beat them. Now, here is another patient. This patient's also had an IVP. This patient, too, is beginning to have post-renal failure because he has a big prostate. The prostate has obstructed flow of urine out of the bladder. That means the urine pressure in the bladder is high. Hasn't distended the bladder, but the poor ureter is trying to pump urine down into it, encounter higher pressure, and they can't really manage to keep the pressure low. So the pelvies, the calyces, the ureters all become dilated compared to what they would be if they were normal over here. Now, seeing that, okay, you can imagine what an ultrasound would look like. There's an ultrasound of somebody in almost exactly the same state. This is a left kidney as if you were looking at it from the front. So there's the upper end of the kidney, there's the lower end of the kidney, there's a renal pelvis, there's a ureter heading south. These are much bigger and more voluminous than they should be under any normal circumstances, and it's a quick, easy, and almost instant way to figure out that of the various things that might be going wrong with his kidneys, it's past the kidney that you need to look for the trouble. The degree to which this sort of obstruction may destroy kidney varies from minimally to completely. Here is a case of the most severe level of hydronephrosis. This thing is none of the ones you've looked at so far. This is an MRI, stands for magnetic resonance imaging. You may have seen them, you may not have. Never mind how we make them. I could sit here for an hour and spout physics at you. Let me simply say that they make pictures which look kind of like CT pictures. They have the advantage of having no ionizing radiation. The disadvantage that they are expensive, time-consuming, not uniformly available. In poor parts of the country, they may be hard to find. And in poor countries, they may be impossible to find. And they involve sticking a patient in a very strong magnetic field, which is kind of hard on the patient if the patient's got a big chunk of metal in him somewhere. I will let you think about the awful circumstances that may bring about. Anyway, here's a patient who had that. This patient has had left proximal ureteral obstruction The pressure inside the collecting system has been so high for so long that that has expanded and virtually destroyed the entire kidney. So that little gray band there is just a little piece of remaining parenchyma. All these white circles are just urine-filled dilated calyces. You know from this, A, what kind of disease the kidney was affected by, and B, what the prognosis where its function is. Not recoverable. So, renal failure radiology may show evidence of all of these. Again, you notice that what I haven't said here is that it shows you a specific disease to identify. Sometimes that happens, but we would be here for hours if we listed them all. You don't really need to know them. But that you know, it can divide them into these categories of things, and it's a good way to start, is a useful thing to keep in mind when you are presented with a patient of renal disease. Keep these in mind and start with ultrasound, and you'll be halfway home. Okay, back to non-pictures.
Okay. All right. Okay, guys. So just getting back to the CKD, and these are extrarenal manifestations. So because the kidney is the center of your body, when it goes down, there's a lot of other consequences besides just a reduced GFR. So hypertension, and we'll talk about all of these: hypertension, cardiovascular disease, acidosis, hyperkalemia, problems with calcium and phosphorus handling in the body, and then anemia. And eventually the filtration rate gets so low that you need to start dialysis to control your volume and your solutes. So anemia. When people develop kidney disease, eventually they will develop anemia, and this is looking at men and women by GFR, what the median hemoglobin levels are. So you can see here that as the GFR gets worse, hemoglobin goes down, and people with very reduced kidney function can often become quite anemic, and we often have to treat this with different things. So the reason for this is you have erythropoietin deficiency because it's made in the kidney, so the bone marrow isn't stimulated to make red blood cells. And then we had talked about this sort of inflammatory milieu that gets activated in CKD, and this also has consequences in causing anemia. So you get destruction of the immature erythroblasts, and in addition to that, there's basically sort of an iron deficiency because you get release of hepcidin, which blocks iron absorption in the intestine and promotes iron release from macrophages. So if you don't have iron and you don't have EPO, you're not going to make red blood cells. And so we treat this often with intravenous iron, and then often we have to give some kind of erythropoietin analog. So I think Dr. Nicholas is speaking to you next, and he's going to go way into depth of calcium and phosphorus, and so I'm not, but I just want to give you sort of a quick overview that another consequence of this is you get mineral disorders, which can lead to bone disease. And a very gross oversimplification is that when you have decreased GFR, you have phosphate retention because the kidney gets rid of phosphorus. You have decreased vitamin D. The 1-alpha hydroxylase in the kidney makes activated vitamin D, and so that's not there, and this leads to hypocalcemia. And all three of these problems are leading to secondary hyperparathyroidism, which he'll get into in detail. And basically that ultimately can lead to bone disease. It's a spectrum of diseases that's basically called renal osteodystrophy. So this is another thing that we're actively looking for and treating when we have a patient with CKD. And he's probably going to show you this, but just this is calcium, phosphorus, and PTH, parathyroid hormone. So you can see as the GFR goes down, the PTH actually starts to rise pretty early as the GFR is declining, even in the face of what would seem to be normal calcium and phosphorus levels. And part of that has to do with the fact that the vitamin D levels we talked about, 25 and 125, the activated form, are declining. Again, he's going to go through this in detail. But those are things that we check for when we have a CKD patient. We're checking calcium, phosphorus, parathyroid hormone, and vitamin D levels and actively managing that. So hypertension is both a cause and a consequence of CKD, and so this is another thing that is very important in the treatment of CKD. So you can see here, this is again looking at GFR. As the GFR is declining, the percent of people with hypertension is increasing. And when you're at low levels of GFR, you're really at almost 90 to 100% of people with hypertension. And this is just showing you a similar thing. As the GFR goes down, the percent of people with hypertension increases. This is greater than 140 over 90 on a blood pressure, or on a blood pressure medicine, and this is greater than 160 over 100. You have about 20% of people with that high blood pressure. So another big consequence of CKD is cardiovascular disease and the morbidity and mortality associated with that. And this is from the New England Journal, a big study that was done in the Kaiser system, looking at the age-standardized rate of cardiovascular events by GFR. So you can see that even at what we would consider not even very advanced CKD, you have increased cardiovascular events. And by the time you're getting to more advanced CKD, this is a huge number of events. And this is really the leading cause of morbidity and mortality at every stage of CKD. And so this is something that really has to be on your radar and that you would be managing, such as lipids and baby aspirin and all the things that you learned in cardiology that you should do to try to reduce somebody's cardiovascular risk. But like diabetes is a huge risk factor for cardiovascular disease, CKD is also. And so why is this? Well, it sort of makes sense because I've told you that in CKD you have anemia, you have extracellular volume expansion, and you have hypertension, and all of those things end up leading to left ventricular hypertrophy. And in addition to that, you have other risk factors. So a lot of people with CKD have diabetes. They have other risk factors like hyperlipidemia for coronary disease. And then in addition to that, you have this sort of uremic milieu, and you have problems with calcium and phosphorus deposition in the blood vessels. So you get accelerated atherosclerosis. And so all of these are sort of the common pathways that lead to very high rates of coronary disease, of MI, heart failure in the population of patients with CKD. So one of the other consequences is uremia. And, we're measuring this by the BUN, or as the BUN, as my group likes to call it. But don't call it that on the wards. So urea is quantitatively, it's the most important solute excreted by the kidney, okay? And we can measure it, so that's what we do, that's what the BUN is. But actually, interestingly, it's actually not thought really to contribute substantially to uremic-like symptoms. So we're measuring it, but there's other organic waste products that probably contribute a lot more to the syndrome of uremia that we just don't measure. If you dialyze somebody and you against a urea bath and you keep their urea up, they'll still have uremic symptoms. I'm sorry, they will not. The uremic symptoms will go away even though the BUN is up because you're able to filter these other organic waste products. And basically, again, when people have very advanced kidney disease and you're trying to decide when do you need to dialyze them, one of the things you're looking for are these uremic symptoms, because once you have this, the only way to get rid of them is basically to do dialysis or to get a kidney transplant because the kidney's not getting rid of this stuff. And you screen patients for symptoms like fatigue, and anorexia is very common, weight loss, nausea, lethargy, sort of changes in mental status. And pruritus is actually a very common complaint, this sort of my skin is so itchy, and it can be very intolerable for patients. So in terms of treatment, you're going to treat any primary disease, right? Because you want to stop the damage. So if you diagnose lupus nephritis, the first thing you're going to do is treat that. Whatever the disease is, if there's a treatment, you're going to treat that first. But there's other things that we target and treat in general in CKD. So proteinuria is very important, and we do that with RAS inhibitors like ACE inhibitors and angiotensin receptor blockers. Hypertension control is extremely important, and we're going to talk more about those too. Glucose control in diabetics, so trying to get people to get their A1C down so the glucose is under better control. And then all the things I just talked to you about, all these extrarenal manifestations, we're monitoring them and we're treating them. It's very important to dose adjust medications. So you calculate the GFR, there are a lot of meds that you have to dose adjust, like antibiotics, some diabetic meds, lots of different things. And that's important to do. So if you see someone's GFR is reduced, you should try to look up all their meds and see if you need to reduce the doses. And then avoiding nephrotoxins. So NSAIDs are huge. I mean, lots of patients take NSAIDs. They have no idea how bad they are for their kidneys. They're popping Advils left and right. So you should always ask about that. And contrast is another one. And then dietary modifications are really important. If people's potassiums are running high, phosphorus is running high, if they're hypertensive, we tell them to have a low-salt diet. So that's also very important. So in terms of, I'm going to focus just a little bit on hypertension and proteinuria. So if you look here, this is the decline in GFR in milliliters per minute per year. And as you go up in quintiles of mean arterial blood pressure, there's a greater decline in the GFR. And it's the same thing with albuminuria. When you're going up in the amount of protein you're excreting in the urine, your decline in GFR goes up. So it makes sense that we would try to treat these things to lower the progression of the kidney disease. So proteinuria, this is extremely, extremely important. So you would be checking and following this in any patient with kidney disease. So you'll get this dipstick. I think we had a case yesterday where the dipstick was 3+. So that just tells you sort of grossly that someone has proteinuria, but you really need to quantify it. There are lots of ways to do this. You can do a 24-hour urine. Again, it's very cumbersome, and in truth, in clinical practice, we very rarely do it. We do it sometimes, but it's really a pain for the patient. So we try not to do it. And there's pretty good correlation between the spot urine, so you just take one urine sample and you run the test. And there's different tests you can order. Okay, there's microalbumin, there's a urine protein and creatinine. They're all sort of looking for the same thing. They're looking for the protein. You need to get the urine creatinine, and you divide because you're trying to figure out how many milligrams of protein per gram of creatinine, okay? So you get a dipstick first, that's sort of a screening test, and then you would quantify the urine protein with a urine protein and creatinine spot sample, not a 24-hour usually. You can do the 24-hour. So just by definition, microalbuminuria is between 30 to 300 milligrams per gram. So this is 30 to 300 milligrams of protein. So really this tells you should really be having no protein in your urine. If you even have 30 milligrams, that's considered microalbuminuria. And in diabetics, that's an absolute sign that damage has started, and we would start an ACE inhibitor even at that low level. And then albuminuria, not as opposed to microalbumin, overt albuminuria is greater than 300 milligrams. And then as you guys, I think, have learned already, nephrotic range is more than 3 grams or 3,000 milligrams. And there is a difference between nephrotic syndrome, which I know you've learned about, and nephrotic range proteinuria. You can have proteinuria like my patient, the one I showed you, the diabetic with 6 grams of protein, but her albumin's normal, she doesn't have edema, she doesn't have nephrotic syndrome, she has nephrotic range proteinuria from diabetes, and that can happen. And then the other thing is just to realize that proteinuria, independent of what your GFR is, just having proteinuria is associated with all-cause mortality, with cardiovascular events, and progression of CKD. And that's the reason why it's a very important target for treatment. And this is just to show you, they're talking about changing the staging of kidney disease if it wasn't already so complicated to something like this. We'll see if that actually happens. But the point is more that the discussion here is because albuminuria is so important in terms of thinking about progression, that you would want to stage somebody by GFR, but also by albuminuria. And that the more albumin you have, you're going into a higher risk category for progression, regardless of what your GFR is. So this is not something that is in clinical use. I'm just making the point to you that when you think about somebody with kidney disease, you really need to be thinking about GFR and proteinuria. It's very important. And this is just showing you that all-cause mortality and cardiovascular mortality are increased as your level of proteinuria increases. This is why it's important. So there have been lots of randomized studies showing that treating proteinuria slows the progression of kidney disease, and we do that by using ACE inhibitors or angiotensin receptor blockers. I think losartan was discussed in the small group yesterday. This is one of those studies from the New England Journal that randomized patients to irbesartan, which is an angiotensin receptor blocker, amlodipine, or placebo, and they followed them and looked for doubling of creatinine or end-stage renal disease, and you can see that there's less of either of these kidney outcomes when you put somebody on an ARB, or there's other studies for ACEs. So this is the first-line therapy. If you have a patient with CKD who has diabetes or proteinuria, this would be the first drug that you would start, and you try to titrate it as much as you can to bring down the proteinuria as much as you can. You do have to watch for things like hyperkalemia, like we talked about yesterday, especially if somebody has significant CKD, but you just start somebody on the drug and you check the labs a week or two later. You know, the reason for why this is working to slow the progression is when you have this RAS activation, you have angiotensin II, its effects on the efferent arteriole, it's increasing pressure in the glomerulus. If you treat with one of these drugs, that effect goes down and it lowers the pressure in the glomerulus. So there's less damage being caused because there's less high pressure in the glomerulus. The flip side of that is your creatinine can go up a little bit, right? Because that's going to reduce your GFR, and that's okay. You can accept about a 30% increase in creatinine if you start somebody on one of these drugs, as long as it doesn't keep going up. Then you have to think about stopping it, or you think about something like a renal artery stenosis. So hypertension is incredibly important to treat in our patients. The goals are somewhat of a controversy. JNC8 just came out with some different goals. I mean, this is one study that just showed that the probability of kidney failure is lower with lower blood pressure control. These particular numbers were not repeated in other studies, and so that's why the recommendation is a little bit different from this. But right now, the recommendation, if you have more than a gram of proteinuria, is you would shoot for a blood pressure of less than 130/80. Otherwise, it's less than 140/90. In a CKD patient, the preferred drug is ACE or ARB, like we just talked about, especially if you have proteinuria. Also diuretics, because in CKD patients, a lot of the hypertension is volume mediated, and so if you give a diuretic, it's very effective. And then basically, just to sort of finish up here, renal replacement therapy, which you're going to get, I think, 2 lectures on. But this is the kind of thing we begin planning for when the GFR is less than 20. You don't usually need dialysis until your GFR is less than 10, but because it requires some planning and education, we start early. And the choices are really a kidney transplant, which in most people is going to be the most beneficial, either living related or deceased donor. You know, deceased donor in New York State, you're looking at a wait of potentially 3 years. So if you have to go on the list, in all likelihood, you're going to need to do some dialysis before. Peritoneal dialysis, this is done through the peritoneal cavity. It's done at home. So it's a home modality, which is nice for patients, but they need to be willing to do it because they're doing it themselves. There's nobody coming and doing it for them. And then hemodialysis is what you're probably most familiar with, where you go on a machine, the blood gets cleaned, it's given back to you. Most of the time it's done in a center. It can also be done at home. And then we put in what's called an AV fistula. That's put in the arm. That's a way to take the blood out and give it back. You'll hear more about it, but that needs to be put in when the GFR is less than 20 because it takes time for it to get big enough that we can use it. So just to finish up here, we talked about CKD, that it's an irreversible loss of renal parenchyma and function, and that the extent of the disease is really only assessed by estimating the GFR. So just looking at the creatinine isn't enough, and you would use one of the formulas that we discussed if the patient's in a steady state. We went through a lot of the different diseases that can cause it. You've learned about many of these diseases. So there's a primary initial insult, and then there's secondary factors that lead to this common pathway of glomerulosclerosis and tubulointerstitial fibrosis. It's a progressive disease in most patients. Many progress to end-stage renal disease, although in older patients, most of them will die from a cardiovascular event before they ever go on dialysis. And then we need to look for extrarenal manifestations like anemia and bone disease, which Dr. Nicholas is going to speak to you more about next. And proteinuria is a very important thing to screen for and to follow because it's an independent risk factor for kidney disease progression and for cardiovascular events. And treating proteinuria and hypertension is really one of the ways that we slow the progression of kidney disease. I mean, we don't have a drug we can give somebody to turn this around, unfortunately, yet. So for us, targeting the protein and the blood pressure is what we do to try to slow the progression as much as we can. And so your interventions are designed to first treat the primary disease that caused the initial insult and then to slow the progression and to avoid nephrotoxins. That's also very important. So thank you. If you have any questions, I can stay or I'm happy to take any questions. Thanks. I'll send it to you. Absolutely. Hey, yes, please.
I was wondering, the inflammatory cascade is that considered a primary or secondary process?
It's really secondary. So you're right. We have the myelin physical inflammation, and we think that the steroid, but it's not the case. No matter what it is, diabetes is not the most inflammatory disease. It ends up with inflammation because of all these things.
Makes sense. Okay, great. Thank you so much.
where do we put the shit?
Oh, it's on the side.
And I had to give her the script for the Tylenol number 3. And it was on my desk. And it's just like the way that, I don't know, Natalia, she was going to be like, she gets too nervous. And she's going to freak out. And she's going to start hammer paging me. And it's just like, no, stop.
Are you going home? You're going to go home before you come?
No, because we had to be at your place by like 6:30, 7 o'clock, right?
Yeah.
I was going to go with you.
I was just going to say, just come with me.
Because I brought my shit for this evening because I need to go over to Craig's place afterwards. Because tomorrow morning we got to get up super early to go to
the tile store.
Go to the tile store. What are we doing? Donde?
I'll go to computer. And then open
Oh. Usually I have my students do this for me. And now what? This thing?
Why isn't it? Oh, maybe put it. Oh, there.
Where?
It's finally. No. Your USB was not.
Is it?
It was. Close it again because
Hi.
it looked like it wasn't.
Are you that?
Oh
yeah,
no
go, yeah.
problem. No problem.
I thought you were the AV person.
You know what? Put it in the other one. I think it's not reading it. I would
Okay.
just put it in the other USB. There's another one.
Oh, it's there. Are you part of the course?
Been coming?
It was really good. Like, I do what
I'm sure if you come, you learn a lot.
No, it is, but it's coming up as a weird thing. Oh my god, I hate this thing.
I like didn't bring the encrypted ones, and that's terrifying.
No, this is what I had at my house this morning. Of course.
I'm gonna just stay around here since we did teaching every hour. Also, they didn't put teaching. Oh, I'm like,
And also, like, they should just upload this for us. I don't understand. It's obnoxious. Is there a window in here where mine's? Is there a window in here where we can like see the next slide? View, slideshow. No, usually it's under slideshow. And whatever. Anyway, so you've been sitting in these lectures?
Yeah.
That's good. I have my ready? It helps to review the physiology. It helps with the We don't do this stuff in practice every day. Yeah, it does fill the gaps, right? I'm gonna start with Hey, good morning, everybody. We should start. And I don't know if anybody's back from their little break. Can you hear me? In the back, can you hear me? Off your iPhones, can you hear me? No, it's on. Okay. So my name is Dr. Nicholas, and today we're going to talk about calcium phosphate metabolism. This is another area of nephrology that something else that the kidney does. In most cases, during this lecture, a lot of the students get confused because we've moved on from the nephron to something else. So let's start now. I'll try and go slow, and then at the end of the lecture, there should be a good 15 minutes for us to have a question and answer session. If there are no questions, that's great. So there are a couple of goals for today's lecture. So you're going to get a brief overview of calcium phosphate normal homeostasis. Now, this is a very brief overview. You will be getting a more complete overview during the endocrinology course. There's going to be some redundancy. That's okay. Remember, medicine is really about pattern recognition, so the more that you hear about different types of disease states and normal states in medicine, it's better for you. So don't worry about the overlap of endo, okay? We're also going to talk about then what the kidney does for calcium phosphate homeostasis and the important role that the kidney plays in maintaining calcium and phosphate levels. And then we'll move on to sort of normal pathophysiology and then talk about therapeutics and renal disease regarding abnormal calcium and phosphate metabolism. Why isn't this? Which way do we go? Okay. So what's the big deal about calcium and phosphate? So calcium and phosphate, they're essential ions that are involved in skeletal development, muscle contraction, cell division, cell signaling, plasma membrane integrity. This is a very nice complete list here. So calcium and phosphate are important, and calcium phosphate levels are regulated and maintained by a multi-system approach between the kidney, the gut, parathyroid gland, and bone. Okay, so this is a very nice demonstration that when we think in medicine, we need to think systemically rather than in just one organ system. And it's the beauty of the kidney and that the kidney coordinates all of these actions. Okay. So there is a normal, continuing on with the normal physiology. So there's a normal feedback pathway. There's a very nice endocrine loop to how all of this happens. And by an endocrine loop, I mean that there is a hormone that's released, there is an endpoint that then feeds back to the beginning of the loop and regulates the release of the hormone, which regulates the end product, and it goes back and forth. That's a typical endocrine loop. And this involves, one, the parathyroid gland. And in the parathyroid gland, there's a receptor called the calcium sensing receptor that senses low serum calcium levels, which then, that's why, okay, which then stimulates the production of a hormone called parathyroid hormone. Parathyroid hormone then goes to the bone, and in the bone, it stimulates these cells called osteoclasts. Don't worry so much about the cell type, but just worry about what they do at this point. And what they do is they dissolve the bone matrix, and they release calcium and phosphate into the serum. And in the kidney, parathyroid hormone results in a couple of actions regarding calcium and phosphate. Remember, so the goal of parathyroid hormone is to maintain serum calcium levels. So it does that by stimulating release from the bone and by stimulating the kidney to actually reabsorb filtered calcium. It also makes the kidney release or excrete more phosphorus, and it results in the production of another hormone, which we call a vitamin in our common parlance, vitamin D, or calcitriol, which is a more proper term for vitamin D. And then in the intestine and the gut, it results in increased calcium and phosphate absorption from the diet. Okay. And what happens next is we'll move on to the synthesis of some of these other hormones that are involved in this pathway. And there was a figure that should have come out, actually, that's not coming out here. So probably on the slide deck that you have in your handout or online, there's a figure here that basically shows the coordinated action of the parathyroid gland, the kidney, bone, and gut. I'm not sure why that's not coming up on here, but I apologize for that. And if you have any questions regarding that figure, we can talk about it after the lecture. So moving on then to vitamin D, so one of the essential components of this pathway. So vitamin D is synthesized by a couple of steps, and I'm sure that you all have read about vitamin D in the lay press over the past couple of years, because this really is it's the hot thing right now. So vitamin D is produced by the coordinated action of skin and the kidney. And we synthesize this form of cholesterol in our liver. It's released into the circulation. And when it hits the skin, by the action of UVB radiation just from sunlight, it's converted into the free vitamin D3. And then based on the temperature, there's a temperature-dependent isomerization of free vitamin D3 into D3. This is not the active hormone yet. This is just vitamin D3, which one can purchase in a store. When you go to CVS or Duane Reade and you buy D3, this is what you buy. Then in the blood, it binds to the binding protein, and then the binding protein circulates, and it circulates to the liver. And in the liver, it undergoes I guess this would be the third step in the process of its production. And at the 25 position, so here, it's hydroxylated. That then binds again to the debinding protein, and it goes to the kidney. And then in the kidney, the final step in this process is completed by the action of an enzyme called 1-alpha hydroxylase. And 1-alpha hydroxylase hydroxylates it at the 1 position, and we wind up with our active hormone, which goes by several names. So I'm going to call it calcitriol. You may read about it in terms of it being called 1,25-dihydroxy vitamin D3, shorthand 1,25-OH2D3, or calcitriol. This is just the active form of the hormone. So once again, in the liver, we have 25-hydroxylase, first step in this, or second step in the process. We have 1-alpha hydroxylase, which is the enzyme that's present in the proximal tubule cell of the kidney, and then we get our active hormone. This is the rate-limiting enzyme here, 1-alpha hydroxylase, and it's highly regulated in, once again, a classic endocrine loop by parathyroid hormone. So parathyroid hormone upregulates 1-alpha hydroxylase. Remember, calcitriol stimulates calcium uptake and calcium balance in the blood, and it's downregulated by, once again, calcium and phosphorus. So you don't want to be hypercalcemic. You want to maintain calcium at a certain level. So it makes sense that calcium and phosphorus would shut off the production of this enzyme. So once again, so high calcitriol also shuts off this enzyme. And there's another hormone called FGF23, fibroblast growth factor 23, which is a very important phosphatonin or regulator of phosphate balance, which also shuts off 1-alpha hydroxylase. Okay. So what's the balance here, and how do these different organ systems affect calcium balance? So what we mentioned, or I mentioned, that the skeleton is involved, the gut's involved, and the kidney is involved. So the skeleton is our main reservoir of calcium. 99% of all of your body's calcium is in your bone. And you have about a kilo of calcium in your bone. Okay? And on a daily basis, just to demonstrate how active and dynamic bone is, and that it's not just a block of calcium, about 500 milligrams of calcium are released daily. So that's about half the calcium load on a daily basis. So there's a lot of activity going on in the bone itself, which is very important later on during this talk when we discuss the abnormalities that occur due to chronic kidney disease. How about the intestine? So the intestine, remember, you eat, you absorb calcium from your diet. You don't absorb all the calcium, though. You only absorb about 20% of what you eat, and there are reasons for that, which we'll talk about in a moment. And then the kidney, in all of its glory, demonstrates that it's the workhorse of all of this system. It filters 10 grams of calcium a day, but yet you're only excreting a very small fraction of what you're filtering. So between 100 to 300 milligrams per day of calcium excreting. It's tremendous. So vitamin D and parathyroid hormone are central to this homeostatic process. There should be, I don't know what's going on here, but there should be another figure here where I believe it's like the intestine, the kidney, and maybe it's bone. Yeah, I'm looking at your iPad here. Yeah, absolutely. So sorry about that. But basically what this figure should be showing us is that in the intestine, you eat, in this figure, you're eating a gram a day, but you're only absorbing 20% of that, as demonstrated here. Then for the kidney portion, it just shows you how much calcium you're filtering and what's coming out in the urine. And then regarding the bone, it just, once again, it's just a demonstration that the majority of the calcium in our body is in bone. Sorry, there's something going on with my slide deck today. So, most calcium is stored in bone. Sorry, I'm going to follow on this iPad. All right, so this is not coming out either. So what you should be seeing here in this figure is just a demonstration of the distribution of calcium in your body. So here should be a bone, and that should demonstrate that 99% or even more than that of the calcium is in your bone. And then we can see the step-off that occurs as we move to the extracellular fluid and to the cells. And really, there's only a little bit of calcium in your extracellular fluid, so 0.1%, and then in your cells, it's just a negligible amount. So when you're measuring a serum calcium, that's the majority where the calcium is. And I'm sure that as you discussed in previous lectures, when you measure potassium, the majority is intracellular, not in your serum, and the opposite for sodium. And for calcium, the majority of that is in your bone. Okay, so next slide then. We'll see if that pops up, but I'm going to move up here. So basically, what this slide is here to demonstrate to you, and the photo and the image in your slide deck actually shows this very nicely, is that there is a limit to what you can absorb of calcium in your diet. So if you're treating patients, and the point behind this is that if you're treating patients that have low serum calcium levels, and you load them up with calcium, they're only going to absorb a fraction of that. And that's important to understand in your therapeutic management. So we get calcium from dairy products and from green leafy vegetables. So think of like broccoli, think of spinach. And only about 20 to 60% of that is absorbed. And so that's about if we eat a gram a day, then we figure between 200 and 600 milligrams are absorbed. And then there's a plateau. Yeah, there's the plateau, but there's no figure. So you'll see the scatter plot on your mobile devices or on your computers. What you see is a scatter plot of dietary calcium on the x-axis, and you'll see on the y-axis your intestinal calcium absorption. And what this red line is supposed to show is that you increase your calcium absorption in your intestine in a linear manner up until you hit about, this is in millimoles, sorry about that, up until you hit about maybe 15 millimoles per day. And then you peak in the amount of calcium that you can absorb. Okay. We'll discuss this at the next slide in a moment. But basically what happens is that through calcium balance studies that you'll learn more about in the endo course, we reach neutral or positive calcium balance at about 400 milligrams of elemental calcium per day. I say elemental because when you get a calcium tablet over the counter, let's say you get Oscal, I'm sure that your parents, your grandmother's probably on Oscal, and it says a gram of calcium on the bottle. It's not a gram of calcium that's being absorbed. The absorbable component is only a fraction of that, and that's what we mean by elemental calcium. We go into negative calcium balance when we're eating less than 200 milligrams of calcium per day. Okay? Let's see what happens next. So there should be, yeah. So so the figure that you're seeing on your mobile devices, these are two cells, okay, and these are two intestinal cells. They're enterocytes. What these two red lines are going to represent are they're pointing to two separate kinds of channels. One is a channel that's inducible by calcitriol, and the other one is a transmembrane, an intracellular gap protein that basically allows calcium to pass through passively. So the efficiency of calcium absorption then really is based upon what we're eating, okay, mainly, okay, and we increase calcium absorption with low levels of intake by eating more, okay, and efficiency increases with low levels of intake because there are hormonal mechanisms that actually increase this inducible channel to take up more calcium. And then as we increase our dietary intake of calcium, that inducible channel by calcitriol is downregulated, and then it becomes more of a passive process. Okay? So here, what this is demonstrating is that the absorption reflects two mechanisms. So there's the cell-mediated absorption that's modulated by calcitriol. Okay? And then the passive diffusion is driven by this transepithelial electrical gradient, and at high levels of calcium intake, the passive diffusion predominates. So the calcium channel that's inducible by calcitriol is shut off because calcitriol is shut off, so then this just becomes a passive process. Okay. So, let's see. Next slide. Is there going to be, no, there's not going to be a speaker here. Okay, all right, so we don't know what's going on. So in this slide, this is just a demonstration of the fact that that the kidney is a workhorse in this system, and that although you're filtering out a huge amount, up to 10 grams of calcium per day, the kidney is absorbing all of that, and 2% is filtered out through the urine in a normal person. And we'll discuss abnormal states next week and how that affects the incidence of kidney stones or of nephrolithiasis. And how is this modulated then? How is the kidney then being the workhorse in the system, and what hormonal and mineral factors modulate this process? Okay. So as I mentioned briefly before, parathyroid hormone really is the main regulator of calcium reabsorption. And it does this through stimulating uptake of calcium in the nephron. And it's actually throughout the nephron that this occurs. And this high PTH levels reduce urinary calcium by increasing calcium absorption in the thick ascending limb, and then it opens a epithelial calcium channel in the distal collecting duct that allows calcium reabsorption to occur. Phosphorus also, elevated phosphorus levels also stimulate calcium reabsorption because they stimulate parathyroid hormone. So this is confusing. Parathyroid hormone in the kidney results in calcium reabsorption, but phosphate excretion. Okay, it does the opposite thing. Okay, and there's a reason for that I'll touch on a little bit later during this talk. Okay. So for renal regulation of calcium, I have a very nice complex slide that's not printing out, and I apologize for that, but I'm going to walk you through it. And I don't want you to memorize this slide, but I want you just to get an understanding of what this means, okay? Because basically the purpose is just to demonstrate that the kidney is reabsorbing calcium throughout the nephron, and that there are different stimuli to calcium reabsorption in different portions of the nephron. I feel like I should be on Sakai and just doing this, or on CourseWorks up on the board. So in the first part of the slide here, we're in the distal tubule, and there are two cell types here, and you see that there is a couple of hormones that are present in the box. So there's parathyroid hormone, or PTH, and there's a phosphatonin, something called a phosphatonin there, which just means that it's a tonic regulator of phosphate called FGF23. So what PTH and FGF23 do is they regulate a channel that's present in the proximal tubule called NaPi2, or it's called the sodium phosphate transmembrane channel, and it's a coporter, and this coporter reabsorbs phosphate and sodium. Thank you very much. for doing that. They reabsorb phosphate into the proximal tubule cell, and PTH and FGF23 shut that transporter off.
I'm just going to look at that video from my question.
Yeah, please do. Hopefully we'll have this fixed in a moment. So they shut off the channel, and when PTH is high and FGF is high, that results in phosphaturia. Okay. What you also see is that parathyroid hormone stimulates the production of 1-alpha hydroxylase, which then results in more calcitriol being produced. What this slide doesn't show you, but which is important to remember, is that FGF23 shuts off calcium. Shuts off calcium 1-alpha hydroxylase. Okay. So the result of that, in the presence of high PTH levels, remember that the goal is to maintain serum calcium, is that we reabsorb more and more calcium, and we get rid of more phosphate. And about 70% of the calcium filter load is reabsorbed in the proximal tubule. Okay. Moving on down the nephron, we move on down to the thick ascending limb, and you see in large another cell type, and this is the sodium potassium 2-chloride channel, and as part of the electrochemical gradient generated by this channel, calcium is passively reabsorbed into the system from the urinary space. And when we shut off that channel, like when we give furosemide or Lasix or a loop diuretic, we shut off that gradient, and we can actually stimulate calcium excretion, which becomes very useful for us when we're treating patients for hypercalcemia. Okay. Moving then further down the nephron to the distal tubule, we see that there is further calcium absorption that occurs, and when we look at the cell type that's there, we can see that there is a protein there called calmodulin, which is a calcium binding protein, and then there's also a pump on the basal surface of the cell, which then takes that calcium that's been reabsorbed and then sends it back into the bloodstream again. And this and that calcium channel that's on the distal tubule cell is inducible by the action of parathyroid hormone. Okay, so I don't want you to memorize this slide, but what I do want you to do is just be familiar with. Sorry, I actually got rid of it. Just to be familiar with the fact that the kidney is very much involved in this process of maintaining calcium balance, and is very responsible for the homeostatic mechanism. Hold on, are we able to?
I could do a very remote change with.
Okay.
You have to scroll it down.
That's fine. All right, guys. Sorry about that. So at least now we have this, and the figures will come up. Okay. Did we miss? You guys are awesome. That's why we admitted you. Okay, so moving on then from calcium. Let's move on then to the next mineral in this process, and let's move on to phosphorus. So phosphorus, is usually kind of, we think of it as being a little bit boring, but actually it's quite important in this process, and it drives a lot of the morbidity and mortality in our patients. So I don't think that phosphorus is appreciated enough. The majority of phosphorus in our body is in bone. Makes sense, since hydroxyapatite is in bone, and it binds with calcium, and it maintains skeletal integrity. Less of it is in cells, and then less of it is in the extracellular fluid. Okay. So, unlike calcium absorption, which has this, this passive and this active thing, the majority of phosphorus absorption in our diet is driven by how much phosphorus we eat, and this is very important when we consider the terror of the modern diet. So the majority of this is passive. So basically, the more phosphorus that you eat, the more that you're going to absorb. soda, modern foods are full of phosphate preservatives, and the more of those that we eat, the more that we're absorbing, and probably it's very, very, very unhealthy for us. And in particular for renal failure patients who can't excrete phosphorus very well because of decreased nephron mass, this actually begins to kill them over the long term. So in a regular diet, about 60 to 80% of the phosphorus that we eat is absorbed, and vitamin D plays really, or calcitriol really plays little role in net phosphorus absorption in the normal person. And the renal failure patient who has problems getting rid of phosphorus, the vitamin D portion of this actually plays a very important role, because whatever phosphorus they absorb from their intestine just hangs around for a very long time, and they can become hyperphosphatemic. So there's a little bit of active transport, in other words, with vitamin D. However, it's kind of not as important in healthy people as it is in CKD patients. Okay. So this is just another example of what the kidney is doing, and how active the proximal tubular cell is in handling phosphate. So 85% of the phosphorus, serum phosphorus, is ultrafiltered. Then that sodium phosphate cotransporter that we talked about briefly comes into play, and it reabsorbs phosphorus. So 85% of its reabsorption occurs in the proximal tubular cell, and then about 12.5% is excreted into the urine. And the figure here just demonstrates, when you do the math, what exactly the kidney is doing. Okay. So this, when you add on the animation, actually looks nice. Here it's kind of sloppy. So what happens here is, this is just a demonstration of how the kidney handles phosphorus and what's the interplay between FGF23, which is a very important regulator in this process. So what is FGF23? FGF23 is a hormone that was identified maybe about 10 years ago, and it was always thought to exist because no one could explain the dynamic nature of phosphate metabolism, just based on calcitriol and parathyroid hormone alone. And then after it was identified, it was found to regulate the sodium phosphate cotransporter, and all of them have been associated with many other horrible things that occur with kidney failure patients, including increased cardiovascular risk, vascular calcifications, and bone disorders. And so what happens is that when you eat a dietary load of phosphorus, or if you just have chronic kidney disease, that stimulates the bone cells to make this protein, to make this hormone called FGF23. FGF23 then in the proximal tubular cell downregulates the production of both types of sodium phosphate cotransporters. So there's MPT2A and 2C, they're downregulated, and it also shuts off calcitriol production. Okay. That results in phosphate wasting, so you get rid of phosphate, and you have less reabsorption of phosphorus into the blood space. And these are one of the essential things here that we'll talk about later on, is that because FGF23 shuts off calcitriol production, this also then begins to drive the incidence, or it begins to drive hyperparathyroidism, which in a normal person is just compensatory to help us maintain our serum calcium levels. But in renal failure patients, this becomes a vicious cycle, and the patients become severely hyperparathyroid, and that results in severe bone disease, vascular calcifications, increases cardiovascular risk. Okay. So that's the basis, or the basic for a normal pathophysiology, and now we're going to move on to abnormal. Okay. And in renal disease, we call this CKD, chronic kidney disease, mineral and bone disorder, and I'm going to call it CKD-NBD. We're not cardiologists, so we're not good at coming up with better names for things. So this is a clumsy name, and we apologize for that. But we're going to review the pathogenesis, how this affects the incidence of vascular calcifications, bone complications, and then how we treat it. So I'm not sure if Dr. Rao showed this image to you. This is like the inverted CKD pyramid, and this just demonstrates that in the general population, we have a lot of patients with CKD stage 1, a lot of patients with CKD stage 2, a lot with 3, and then we have a couple with 4 and 5. And that's a little bit of a weird step down between 7.5 million to 300,000. And one could probably suggest or think about why that happens. And if I were just to ask anybody in the crowd, what would you guess? They're dying. And what do they die from? They usually die from cardiovascular disease, typically related to CKD-MBD. So CKD-MBD basically is just this whole entire system of vitamin D, PTH, and calcium phosphate metabolism gone haywire. So what happens is that when you have decreased GFR, you have decreased nephron mass. Okay, so you have decreased ability to filter phosphorus. You have decreased production of 1-alpha of calcitriol because proximal tubule cells are involved in this process, and if they're not present, then you just can't make vitamin D. So you have decreased vitamin D hormone synthesis and metabolism, and then you have increased phosphate. So you have hyperphosphatemia that begins to ensue. Due to the combined action of having less calcitriol and more phosphate, okay, you have decreased calcium absorption from the GI tract, okay, and phosphate and calcium like to bind together, okay, and when they bind together, that lowers the plasma calcium even more so. So you have hypocalcemia or lower levels of serum calcium that begin to occur. This is a very strong stimulus, both decreased vitamin D, hypocalcemia, and hyperphosphatemia to increase parathyroid hormone production to correct these abnormalities. But because the abnormalities can't be corrected, because there's no nephron mass to make vitamin D, there's no nephron mass to get rid of phosphorus, this then becomes a very vicious cycle. And what happens is that excess PTH then, because there's more of it hanging around, stimulates bone resorption, which means bone demineralization, because PTH stimulates osteoclasts to demineralize bone because it wants to release more calcium to get rid of the hypocalcemia. And that results in a syndrome or a spectrum of bone disorders that we call the renal osteodystrophies. And then it results, once again, as I mentioned before, something called an increased calcium phosphate product. So calcium and phosphate, they bind. That's the calcium phosphate product. And then that results in metastatic calcifications, or basically calcium deposits in soft tissue, so muscle, and also, and the one that we worry the most about is that it deposits in your arteries, and it causes severe stiffening of the arteries. Not included on this is that FGF23 also is part of this process, and it results in left ventricular hypertrophy. Okay. So really, CKD-MBD, is not just a disorder of calcium and phosphate and PTH, but this is a systemic syndrome that involves the kidney, skeleton, parathyroid glands, cardiovascular system, and soft tissues. And to delineate the disorders, we can itemize them. Hyperparathyroidism is the parathyroid problem. In terms of cardiovascular disease, we have increased risk of heart attack and stroke. The bone side is these patients get fractures, and then on the soft tissue side, they get something called ectopic calcifications. So to take a look at what's going on in this process, and if you break it down, so we mentioned before that in normals, people with normal kidney function, vitamin D3 goes to the liver, gets hydroxylated at the 25 spot in the kidney. 1-alpha hydroxylase then hydroxylates it at the 1 spot. However, in the kidney, because 1-alpha hydroxylase isn't present, this step is removed. So that's why calcitriol levels are low. Regarding phosphate, brief overview again. Phosphate levels go up, stimulates the production of more parathyroid hormone, because remember, PTH stimulates renal phosphate excretion. FGF23 also is stimulated by hyperphosphatemia. That also wants to signal back to the kidney to excrete more phosphate. However, that's not really happening. Calcitriol levels are decreasing, and calcium levels are decreasing, although the bone is trying to release it, it still can't compensate. So when we move on to then the end organ complications of this process, we'll start with bone. So you'll learn this in more detail in your endocrine course, but bone has an inherent activity rate, and there are bone-forming cells called osteoblasts, and there are bone-resorbing cells called osteoclasts. And there's a very nice, elegant hormonal paracrine pathway by which these two cell types are what we say are coupled together. So your body is always maintaining the integrity of your skeleton. You go for a run, we say you should do weight-bearing exercise because that helps your bone keep strong. Because what happens is that as you run, you induce some damage. These osteoclasts come in, they break down the bone. That signals to the osteoblasts to come in, and they come in and they reform the bone. And our skeleton is doing this every single day. And every 10 years, our body makes a whole new skeleton. So it's quite an interesting process. So there's an inherent normal remodeling rate that occurs. When there's imbalance in this system and the two cell types are uncoupled, major problems can occur. And this is what happens in the renal osteodystrophies. So patients with renal osteodystrophy can have either formation that is too high and resorption that's too low, or the opposite. They can shut off formation and they can have resorption rates that are too high. When bone formation is shut off completely, we call that adynamic bone disease. And when bone resorption is very high, we call that hyperparathyroidism bone disease, or the classic term for this is osteitis fibrosa cystica. Both of these disorders are associated with broken bones. And unfortunately, the risk of fractures in our patients with renal failure are quite high. And when we compare risk to that of the general population, it's about 200% more common. And after hip fracture, which is really the most, all fractures are severe, but hip fracture is the most severe because it results in the most morbidity, meaning patients can't walk around, they're in bed for a long time. Many of them need surgery to fix the fracture. Many of them need long-term or short-term physical therapy and rehab afterwards. And the mortality rates also increase after hip fracture because when you have a patient who's sitting down for a long time or lying in bed for a long time, there are risks for things like pneumonia. Some of them get heart attacks. So risk of death after a hip fracture is about 200% more common than a general population person who also has a fracture. So we take these things very seriously and we worry about them a lot. The next thing that we worry about with CKD and MBD is the risk of vascular calcifications. So I showed you that inverted pyramid before where we have a lot of our patients dying between the CKD stage 3 and 4. A lot of that's being driven by cardiovascular risk, and cardiovascular disease is the #1 killer of our patients. And this is a demonstration of why. I mentioned harboring of the arteries due to this calcification process. And here, what you're seeing is the spine. Okay. Here you're seeing a blood vessel called the aorta. This should not be visible in an X-ray. You shouldn't see this, but here you're seeing a very nice aorta because if you look at the wall, it's full of calcium. And I'm sure that when you were in your cardiovascular block, you learned about atherosclerosis and intimal calcifications. The kind of calcifications that our renal failure patients get is very different than what people with healthy kidney function get, because these calcifications aren't occurring in the intima, they're occurring in the media, so they're occurring in the middle layer. And what happens is that the smooth muscle cells, for some reason which we don't really understand yet why this happens, they turn into bone-forming cells. So there's a transdifferentiation of vascular smooth muscle cells to an osteoblast-like cell that lays down bone mineral in the media of large and medium-sized arteries, and that is a very common reason why our patients have not just heart attacks and strokes, but also peripheral vascular disease and progressive amputations. So one of the drivers of this process is thought to be phosphate. And hyperphosphatemia has been shown in many epidemiologic studies to correlate very highly with death rates. And here, this is just a demonstration of one of the earliest studies that founded this association. So what you see here is levels of phosphate on the X and relative risk of mortality on the Y. And normal phosphate levels are somewhere between, at least in our lab, between 3 and about 4.5, 5. And in this study, they showed that once phosphate levels were even a little bit above normal, at 5.5, risk began to increase to being 39% greater in patients with phosphate levels in the 7 range. So one of our therapeutic goals in treating our CKD patients is to get their phosphate down to normal, and we'll talk about that in a moment. So moving on to treatment, our goal then in treating CKD-MBD is really to try and correct the abnormalities that have occurred due to bad kidney function. This sort of works well. It's always hard to replace the function of an organ. However, our goal is to maintain vitamin D levels at somewhere near normal, to get phosphate down to normal, and then to maintain PTH also at something, PTH and calcium near normal, as best as we can. When does this begin to occur in the CKD process? Dr. Rao talked about CKD stages. Is that correct? Yes? No? Yes, great. I wasn't here for her lecture, so I don't know what she discussed. But so CKD stages. So what's demonstrated here is that you have GFR on the X, and CKD stage 3, which is where we begin to have decreased levels of GFR, are right here at about 60, right? So we would think that the beginning of these abnormalities should begin to occur sometime when nephron mass is actually decreased. It's not the case. And what happens is that even when CKD is in its earliest phases, we see the beginnings of these abnormalities. So what happens is that even when your patient that has CKD, even when their GFR is in the range of, let's say, 80, as shown here, about 15% of your patients are going to have some abnormality that we associate with MBD. And in this case, the first thing that begins to show up is abnormalities in parathyroid hormone, so hyperparathyroidism. Why does that occur? That occurs because even before this happens, there's some signal that the kidney sends to the bone. We don't know what the signal is, but there's some signal that stimulates the bone cells to make FGF23. And when FGF23 levels begin to go up, that results in very, very subtle abnormalities, most likely in calcitriol production, which then results in some mild hyperparathyroidism. The first thing that we see. The severity of that then begins to decrease over time as both nephron mass decreases and the ability to excrete phosphorus also decreases. And by the time that our patients reach a GFR of 20, or that's CKD stage 4, okay, about 80% of the patients have hyperparathyroidism. Okay, regarding abnormalities in 25D, so cholecalciferol, or D3, calcitriol, okay, they also begin to occur a little early also. And in fact, by the time that somebody has a GFR of 80, kind of normal, unless you have CKD stage 2, then about 15% have also abnormalities in calcitriol production, which correlates very nicely with the incidence of, or the prevalence of abnormalities in PTH. Okay? So in other words, these abnormalities begin early, and when it's on our radar, we recognize it and we try and treat it. Okay. So the first thing that we do is that we try and normalize vitamin D. And there are two ways to do this. So I mentioned that when nephron mass decreases, that 1-alpha hydroxylase levels are down and that calcitriol production is down. However, we don't start giving calcitriol to our patients until they have severe renal failure, because you can actually game the system by giving them the pre-product and overloading the system with the pre-product to try and drive the rate forward to making the 1-alpha hydroxylase. And we do this by giving what we call parent vitamin D, or D3. There are two forms. There's ergocalciferol, or D2, and cholecalciferol, D3. What's the difference? And it's very subtle.
Ergo, or D2, is a plant-based parent vitamin D. Cholecalciferol is what we make. So it's the animal form of vitamin D3. When you go to your local pharmacy and you buy D3 over the counter, you're buying cholecalciferol. If you have a vegan, they will not take cholecalciferol, okay? But they can take Ergo. It's the same thing, same result, doesn't matter, okay? That's the only difference really that I've encountered with these two products, that my vegan patients won't take D3, but they'll take D2. For the active vitamin D, we have a couple of flavors here. These have all been synthesized for various special properties. Whether this truly pans out in clinical practice is debatable. So active calcitriol then is the active form of vitamin D that's already been hydroxylated at the 1-alpha position, so it doesn't need the kidney to make it active. When you give parent D, that needs the kidney, so patients need to have enough renal mass to convert it. However, for our patients with end-stage disease or CKD stage 4 or 5, they don't have enough renal mass to convert it, to convert parent D, so we give them active D. Alpha-calcidiol, something that you may read about. It's not in use in this country, but it's in use in Japan and Europe. Paracalcitol and doxorcalciferol are synthetic forms of vitamin D that are supposed to be less hyperphosphatemic, so they have less affinity for the vitamin D receptor in the intestine. And then calcitriol is just run-of-the-mill active vitamin D that actually works very well. So we give any of these drugs to our patients depending on what our practice pattern preferences are. How well do they work in treating hyperparathyroidism? They work excellent. And these data here are just to demonstrate the efficacy of these products or of these drugs across the spectrum of renal failure. So what you see here in the first figure is two groups of patients, one with stage 3 CKD, one with stage 4 CKD. So remember here you have enough renal mass to convert 25 to 125, and here you probably don't. What this study did was that they gave patients either, so they gave patients, let me make sure I see this. So here you have baseline, and here you have post-treatment. They gave patients 25 vitamin D, and they looked at conversion to 125. So here you have, at baseline, the mean vitamin D level. They treated them with 25D. It went up. It's great. And then they looked at the end product. And here you have levels of 125D both before treatment and after treatment. In the group with stage 3 CKD, levels of active D increased with supplementation of parent D. But in the patients with stage 4 CKD, although after treatment with 25D or with cholecalciferol, although levels increased, levels of calcitriol did not increase. So just a demonstration that you have reduced efficacy of giving this drug to patients with stage 4 CKD. And then when they looked at the efficacy in getting PTH down, since that's the goal, okay, they found that in patients who had stage 3 CKD, so here in the solid line, that after treatment with 25, they had a 15% reduction in PTH, versus with stage 4 CKD, there was no change with giving parent D. So confirming that it's good to give parent D for other reasons, but for getting PTH down, once our patients hit CKD stage 4, we need to be more aggressive. Okay, and there are some other ways that we can be more aggressive. And we hit late-stage CKD by combining approaches. So not only do we give calcitriol, but we also target low phosphorus or high phosphorus. These are very old data, and this is a very nice demonstration about how responsive our bodies are to hyperphosphatemia, and how just by limiting phosphate intake that we can control high PTH levels. So these are data from 1970. This was in dogs, and what they did was they gave dogs sequential kidney failure over time, and then they assigned these animals to two diets. One was a regular diet, and one was a very low phosphate diet. And what they demonstrated was that over the course of their renal failure, if they were on a low phosphate diet, their PTH remained low and didn't change. but when they were eating a normal diet, phosphate levels increased. So based on these data, we in the clinic will encourage a low phosphate diet, and we also have drugs that we give that decrease the intestinal absorption of phosphate. So it sounds easy, but it's not. And the reason why it's not is that, I mean, as you can imagine, phosphate's everywhere, and in particular it's in protein. It's in dairy, beans, and cereals. So when we limit our patients from eating phosphate, we run the risk of making them malnourished, which is bad for them because it also increases their mortality rates. And this also is very hard in the current era because a lot of the additives in our food products are full of phosphate. And I mean, one of the biggest culprits is soda and processed foods. And it becomes very hard in impoverished communities in our area here in northern Manhattan to control phosphate levels because they're eating things that aren't very healthy. They're drinking a ton of sodas, and it becomes very hard to control phosphate in these patients. So when we fail dietary management, then we move on to pharmacologic management. And we have a battery of drugs that are called phosphate binders that operate in the intestine, and they prevent the intestine from absorbing phosphorus. It's very nice and easy pharmacology. So these drugs come in several flavors. We have calcium-containing phosphate binders, and we have non-calcium-containing phosphate binders. So the calcium flavor comes in the form of TUMS, so calcium carbonate, or something called Phoslo, which is calcium acetate. The problem with these, as I mentioned before, is that we also worry about vascular calcification, which is driven by serum levels of phosphorus and calcium. So when we give these drugs to our patients, we run the risk of making our patients go into positive calcium balance. And we try and limit calcium intake in our renal failure patients also because they do run this risk. And we try and limit that to about 1.5 grams of calcium per day. And just as an aside, there's no difference between these two drugs and their ability for us to uptake their calcium. So when we give 1 gram of calcium carbonate and 1 gram of calcium acetate, the amount of elemental calcium is basically the same. So how do we know how much calcium CKD patients need? There have been a couple of studies that have been done to look at what level of calcium drives positive calcium balance in our renal failure patients. I'm just going to present these very briefly. I don't think that you need to memorize this. But basically, calcium balance studies are very hard to do because they require that you're admitted to a metabolic unit for a few days, that they give you a MUSH diet, and then they collect your urine and stool, and they measure how much calcium is present in and out. And they determine whether you're a negative, positive, or even calcium balance. So these are cumbersome to do and they're very expensive. So there are a few of these that have been done. What this very nice study did was they took a bunch of kidney patients and they put them on 2 diets. They spent 9 days on the diet with either 800 milligrams of calcium or 2 grams of calcium. Then they crossed over and they did a 9-day diet of, if they took 2 grams, then they went to 800. If they were 800, then they went to 2 grams. What they showed was that in the group of patients with kidney disease, so there was also a healthy control group in there, in the CKD group, they found that if patients were eating about 800 a day, that they were pretty much in calcium balance. If they were eating about 2 grams a day, they went into significant calcium overload. And the reason for that is that with decreased nephron mass, they are unable to get rid of the calcium load. So based on this data and on another study, we assume that in general our CKD patients need about 1 gram a day. Okay, and that's what we shoot for. So given that we're also worried about the phosphate and that we've been giving all of these calcium phosphate binders to our patients, and some of them can be in substantial amounts of calcium per day, up to 3 grams a day to control their serum phosphorus, there was a big interest in developing non-calcium containing phosphate binders. And these are agents that are very effective, they don't contain calcium, and they're actually much better for our patients because they have been associated with less cardiovascular risk. There are 3 of them. Sevelamer, which is this cationic polymer lanthanum, which is a rare earth element with great phosphate binding properties. And then there's an old drug that we used to use very frequently called Amphigel or aluminum hydroxide. We no longer use this drug because it's been associated with dementia and with severe bone disease. However, it's an extremely effective calcium phosphate binder, so we will use it in settings of severe hyperphosphatemia when there are potential and serious consequences that may occur. I mentioned that the non-calcium binders were better for our patients, and this is just a demonstration from one of the studies that was conducted, actually a meta-analysis of multiple studies, which showed that there was a 20% reduction in mortality in our patients if they receive a non-calcium binder compared to a calcium binder. So we really try and push the non-calcium binders when we can to get phosphate down. Okay, so this is to sort of summarize. Just the take-home points here are that through the coordinated action of the parathyroid glands, kidney, and intestine, and bone, we maintain calcium and phosphate homeostasis. We'll get a lot more detail on this in the endocrine course. In renal failure, due to abnormal production of calcitriol and phosphate retention, this leads to this pervasive disorder called CKD-NBD, which results in increased risk of bone disease and fractures, cardiovascular risk, and stroke. And then we manage CKD-NBD by controlling phosphate, calcium, and vitamin D levels, and we try and simulate the homeostasis that is maintained by the kidney. We don't do a very great job of it, but it's really all that we can do at this point. And if you have any questions, I'm now open to them. No, no worries. Just keep doing this. No, thank you for doing that. That was great. I don't know what happened.